Aspirin is an antiplatelet drug which is used to prevent blood clot. Thus, it can be used to prevent secondary prevention of heart disease. However, some patients may have side effects, or some patients may not have effects. Hi, Assalamualaikum. I'm Baharudin Ibrahim, and today I'm going to share on one of the relatively new techniques called as pharmacometabonomics in determining which patients will have the GI toxicity or the resistance of aspirin. So as I mentioned earlier, aspirin is one of the most widely used drugs and is usually used for secondary prevention of heart disease. And now sometimes it may be also be used for the cancer prevention. So however, even though aspirin is sort of known as like a magic bullet or a drug which can have a very good effect, however, its main setback is the side effects, which is the GI bleeding. And the second one is it may also have resistance, which means patients may not actually have the effects of the aspirin. So there's a term called as personalized medicine, which is the main umbrella of all the omics. So personalized or sexual healthcare is an important goal for medicine in the 21st century in order to ensure that patients receive treatment that are safe and efficacious. So the main thing here, as I mentioned earlier, there are two components. One is the toxicity, which is for the safety. The second one is the efficacy. In this case, is aspirin resistance. So some progress has been made in this area, especially in pharmacogenomics. Genetic profile of patient or infection agents used to predict the outcome of drug dosing in terms of efficacy, safety, and pharmacokinetics. So pharmacogenomics has been quite established. So now we are moving further away from pharmacogenomics into proteomics and now metabolomics. So improved personalized medicine can be achieved with the help of information from metabolomics, which is distinguished from genomics by two critical points. So the main difference of metabolomics and others and genomics is mainly one, metabolomics. It also can also capture the information on the genetics and also the environmental factors. Okay, I will come to this after this. It reports on the actual physiological state of a person as opposed to a state that might exist in the future. Okay. So this is how the omics works. Okay, so of course the fundamental of the system biology is the genomics. Okay, you have the DNA and so on, and then it will be transcribed to transcriptomics and then translated to proteomics, and then it will make all the functions, the biochemical pathways, which will produce the metabolomics, which also involved in those pathways. So genetics is quite static, but metabolomics will be affected by the environmental factors. For example, your gut microbiota can interact with the biochemistry pathways. Then that can affect the way your drug is metabolized and so on. So that's why studying the metabolomics can give a clearer picture on how the not just the genetic but also the environmental factors affect the drug response. So what's pharmacometabolomics? Pharmacometabolomics is defined as the prediction of the outcome, efficacy or toxicity of a drug or xenobiotic intervention in an individual based on mathematical model of pre-intervention metabolite signature. So that means before you start the treatment, you take their metabolite profile, and using that information, you should be able to predict how the patient is going to respond to the drug, whether going to have side effects or going to have the resistance. The method of profiling equivalent of pharmacogenomics considers that some humans respond differently to drug interaction because they are differentiated predose phenotypes predispose them to do so. Okay, the predose phenotypes are influenced by the subject genome, environment, and also the status of their microbiome. So they are not just genetic, but there are other factors which can affect the drug response. So that's why now we are looking at the metabolomics instead of the genomics per se. So why pharmacometabolomics? Drug therapy is challenged by the fact that many drugs do not work or are unsafe in significant segments of the patient population. So a lot of patients can have diverse effects of drug, especially like cancer drugs. They have quite a different effects of the patients in terms of toxicity on also the efficacy. Seeks to develop methodologies that enable clinicians to know in advance of dosing which drugs will be both efficacious and safe in their patients. The pure human genomics is almost blind to environmental elements. And this is a major reason that pharmacogenomics alone will be less sensitive or specific than design. So it's good to include other components, proteomics and metabolomics, to study the effects of a drug. So for the aspirin GI toxicity, so despite the fact that aspirin reduces the risk of cardiovascular events, it is well documented that it can also damage the GIT. So the reason why some people develop serious lesions, whereas most only have minor clinically irrelevant lesions, are poorly understood. Some patients have side effects, some patients don't. So how this happens is also poorly understood. And GI adverse event is a major factor limiting the widespread use of aspirin. So many patients actually stop taking aspirin because of the side effects. And major cause of therapy discontinuation or non-adherence to the therapy. So one of the major non-adherence reasons of aspirin is the GI toxicity. And people assume treatment failure and aspirin resistance, but actually patient is not taking the aspirin. So based on the available data, no studies try to explore GI treatment of aspirin using pharmacometabonomics approach. So in this research, we are going to look at, are we able to predict the GI toxicity or resistance for aspirin using the pharmacometabolomics approach? So how we did this, there are three groups. One is low dose aspirin, LDA. Another one is high dose aspirin, we use it as positive control, and one is the negative control groups, which is no treatment. Okay, so we did this study in rats, not humans, because we want to induce the toxicity. So we don't want to use humans at this point. This is just a proof of concept study. In the treatment group, there's 32. There's a positive control group, there's 10, and then negative control group, there's 10. And we take pre-dose bifree, which is serum. So that means pre-dose. Okay, before we start the aspirin, we take the sample, and then of course we look at the NMR spectroscopy, the serum profile. We also did the serum thromboxane B2 analysis because we want to know the resistance of the patients towards the aspirin. Okay. And then we give them the daily dose of the aspirin for 28 days, and then we took post-dose bifree sampling. Then we euthanize the rats, and we harvest the stomach to see whether there is any side effect or GI toxicity using stereo microscopy. So from the results, what we got is from the vehicle, which is the control group, we only get 8 rats, we got 2 died. From the 8 rats, none of them having any GI toxicity. Okay, and then from the high dose aspirin group, we had 10 rats. 2 had no toxicity, but 8 has toxicity. Okay, so that's quite high, but of course it's high dose. And the low dose aspirin, which is the standard dose when we compare to humans, we had from 32, 12 has no toxicity, and 20 had toxic effect. That means about 60% of the rats actually having GI toxicity. This is quite bad. Means there are possibly a lot of patients can have GI toxicity when they even take low dose aspirin. Because aspirin don't just affect the stomach lining, but it also block the prostaglandin, which can also lead to the bleeding or ulceration. So this is how it looks like when we harvest the stomach. There are different type of lesions. So A is no lesions, B is the red streaks, it's just minor, and then C is a bit pétaché, and then D is having small lesions, and then E you can see the ulcers there, and F you see hemorrhagic ulceration. So this is how we categorize. But if the patient comes with any B to F category, we classify them as having GI toxicity. And then when we look at the metabolites, remember pre-dose, and then we try to link them with the GI toxicity, we found that these metabolites, citrate, methylamine, trimethylamine N-oxide, hippurate, valine, lactate, acid, pyruvate, these metabolites able to predict which rats will have toxic, which rats will not have toxic. And then when we look at the resistance, we found that lactate, trimethylamine N-oxide, and 4-hydroxyphenyl acetate, they are able to predict which rats will have aspirin resistance and which will not have the resistance. So this study shows a 62.5% incidence of gastric lesion for the low dose aspirin, and this was in the main experiment group, mimicking a standard dose of 100 milligram aspirin for 60 kg human. So this is a standard dose of aspirin in human. for the secondary prevention of heart disease. And although this study was carried out in mice, it corroborates with that in humans and serves as a pilot study which will be validated in humans. In essence, this study clearly depicts that GI is still a problem with low-dose aspirin and pharmacometabonomics techniques able to predict aspirin toxicity and resistance with high accuracy. With that, thank you.